Good evening, everyone. This is Dr. Monica Singh from Bhopal, the MOC for today's evening. And I'm very delighted to have the inaugural Infertility Symposium of the Benchmark series hosted by Dr. Sneha Bihar on the 7th of March, 6 to 8 p.m. We have a galaxy of speakers today evening. Dr. Sneha is there, and we have Dr. Sanjeeva Reddy for the second talk. For the third talk, we have Dr. C.B. Nagori. And for the fourth talk, we have got Dr. Asha Bakshi. We are so indebted to our President ISAR, Dr. Amit Patki, who has joined. We are very happy that Dr. Parag is with us, Dr. Naren Malhotra is with us, Dr. Sonia Malik is with us. And I bring greetings to all of you. Uh, Benchmark is actually giving your best to anything. And today's great work actually forms tomorrow's benchmark. So, benchmark is actually a comparison, but comparison in a very positive way. So, when a person achieves a level of perfection or skill in a certain area, that forms a benchmark for others to follow and to emulate. So I congratulate Dr. Sneha Bihar for having started this series, benchmark series. And we contemplated a lot before coming and zeroing on this name. So can I have Madam's CV, please? My co-MOC for today is Dr. Manisha Jain. There is a lot which can be spoken about Dr. Sneha Vihar, and she has been the recipient of several national and international awards throughout her brilliant career of more than 3 decades, a very hard-working obstetrician, and she has been the recipient of the International MS Signature Award for Phenomenal Leadership in 2020, Asia GCC Award, and I'm very delighted to speak about the Dr. S.N. Malhotra Individual National Award she got for being an unsung hero in her outstanding work in rural obstetrics. Dr. Naren Malhotra is here, and he must be so pleased to listen to this. And she's also been the recipient of Dr. Durusha Distinguished Community Service National Individual Award. At present, she is the chairperson of AMOG's Medical Disorders Committee, and a, a very sincere, dedicated, hardworking gynecologist, a very good leader, mentor, very soft spoken, humble. And madam, it's my pleasure
Thank
to,
you.
be working with you. And now I hand over the program to you to introduce our dignitaries and carry it forward.
Yes. Thank you so much, Monica, for that a very generous and kind introduction, I would say. A very good evening to one and all. At the outset, I would like to welcome respected Dr. Amit Patki, sir, the President ISAR, Madam Nandita Parshidkar, will be joining in a short while after the interview with Times of India uh, as chief guest. And of course, I welcome Madam Sonia Malik, the past president of IFS, Dr. Himanshu Rai, who is the secretary of Bihar chapter ISA, IFS, and of course, special guests who are really not only for this program, but very special for me all the time, respected Dr. Narendra Malhotra and Madam Jayant Kanan. A hearty welcome to all of you. I welcome today's esteemed faculties, respected Dr. C.P. Nagori sir, Dr. Sanjeeva Reddy, and of course the Dr. Asha Bakshi, who is the Secretary General of ISAR. My dear friends, all the chairperson, Dr. Parag Biniwale, Kalyan Baramde, Lavanya Kiran, and Dr. Seema Pandey, who is recently the librarian for ISAR. Dr. Charmila, my dear friend, Vice President of Foxy, Dr. Leena Patankar, a multi-talented, multitasking person, the Director of Patankar Hospital, and of course, Monica Singh and Manisha Jain, my dear friends, who is coordinating this program today. We have tried to cover the basics of infertility, right from evaluation and counseling, impact of the paternal age on the offspring, how to improve the IUI results, and of course, the most questioned, most discussed, but I would say still unanswered, unexplained infertility. I'm sure the best of the faculties is going to make this very useful. With this, I thank all of you for accepting our invite. I humbly seek all of your blessings to my candidature as Foxy Vice President from West Zone for the upcoming elections. And with this, may I introduce my mentors and the chief guest for today's program. First, Dr. Amit Patki and Madam Nandita will be joining later. So we would request Dr. Narendra Malhotra after this. So Amit Patki, sir, all of you know, he's the president of ISAR at present, medical director of Fertility Associates Mumbai, honorary associate professor of K.J. Somaya Medical College, and sir is he has so many colleagues and hold so many posts. Definitely, his presidential tenure is going to, take this ISAR at a newer height. And sir, we are looking forward to your tenure and, of course, blessings for all of us from your side. So with this, I hand over the forum mic to you, sir, for your precious words.
A
Over
very
to
good
Amit,
evening.
sir.
A very good evening, and thank you very much for inviting me for your inaugural benchmark series. I'm extremely happy to see that you have started with the infertility series. I have known Dr. Sneha and observed her for many years. She is a perfect grassroots worker who has worked in rural obstetrics and has taken up leadership responsibilities not only at the state but also at the national level. I'm sure Dr. Sneha will move up, and I wish her the very best for her future endeavors, including the vice president at Foxy. I'm sure the benchmark series will stand up to its name of being benchmark, not only in the topics that are selected, but also in the speakers that will speak in this series. And I'm so happy that she has chosen the right people for this inaugural session. So I wish you all the very best. And I'm as excited to listen to this galaxy of speakers as you all are. So best of luck to the benchmark series and a very uh, uh, happy beginnings to you, Dr. Sneha. Thank you.
Thank you so much, Amit, sir. Thank you so much for your blessings as well. Drakala, can we have a CV of Dr. Narendra Malhotra, sir? Sir, I have been known since long, almost 2007. I would say it was my first step towards Foxy. And with Madam Jaideep and Naren sir, I have started walking towards the route of Foxy. And definitely, it is my pride and privilege to introduce sir. Rather than reading this very busy slide, I would just say, just name the organization, and sir has headed it. All of you know him as past president of Foxy, Ispatch, and whatnot. But then I would just say, sir is such a inclusive person, very encouraging, taking connecting all the generations together, and of course the various levels of the two-tier or three-tier tiers of the Foxys. Also, I would say, and we are very happy to have you, sir, as a special guest, and your blessings will definitely make a difference. We would like to hear from you, your precious words. Over to you, sir.
So, very good evening to all of you. It's indeed a pleasure to be here on the eve of Mahashivratri and on the eve of uh, International Women's Day. So, very, very happy International Women's Day. By the way, it is Mathematics Day today. So, that makes it more confusing for us to add on into our brain. It's indeed a pleasure to be in the inaugural of this benchmark series. The word benchmark says that we're going to establish a benchmark for the academics in various topics. And what better than to start with infertility? And what better in infertility, because still the obstetricians and gynecologists were busy doing a lot of obstetrics, but because they do a lot of obstetrics, they get a lot of infertility patients also, the family, and they want to talk to this OBGYN only. And that is where the evaluation becomes very important, because a lot of times we are seeing that clomiphene is started without tubal testing. Clomiphene is started without doing a semen analysis. Some basic tests are missed. Infection screenings are missed. So that is what is needed. a thorough evaluation, physical, gynec, including per speculum examination, ultrasound, and the blood test, and of course a good well done ultrasound. So that is what I'm sure Sneha will bring that out. And then of course we forget the father part. So paternal age, paternal obesity, paternal BMI, paternal smoking habits, lifestyle plays a very important role in infertility, and that we have been understanding now. And I'm sure Dr. Sanjeeva Reddy will bring this out very clearly, and all of us should be talking to the couple as it and investigating the male also equally on the first visit only. Then, of course, we have Dr. Nagori on telling you how to get the best out of IUI results, and Asha Bakshi trying to decipher the unexplained infertility, which is again very important. So, congratulations, Dr. Sneha, for this benchmark series and for choosing these topics and choosing the right people for this topic. I'm very pleased, and I wish all you luck in this series and in your future endeavors with Foxy, with SR, with the other organizations. A very happy International Women's Day to all of you once again. Thank you for inviting me here.
Thank you so much, sir. Thank you for your blessings and your wholehearted support. Definitely, it's going to boost our morale as well. Thank you, sir. Now I invite our guest of honor, Trikala. Can we have the CVs, please? So we have Madam Sonia Malik. I would say a very elegant, very soft, and a persona which you would love to be. Very kind-hearted person, knowledgeable yet very humble, and of course inclusive and appreciating everybody. Definitely, all of you know Madam as past president of IFA and such a illustrious person with highly decorated CV. Madam, we would love to have your precious words from you. Over to you, Madam.
Good evening to everyone once again. First of all, thank you so much, Sneha, for having me here and choosing me for this inaugural session of yours. As the others have said, as Amit has said and Narendra has said, the title, and as Monica said, after a lot of debating, you have actually arrived at this particular title for your series, which I think is what you are. I know both of you, Sneha as well as Monica. Both of you are kind of similar. You are a little senior than Monica, but I think she and you both want to set standards. You want to set benchmarks. And therefore, this title is absolutely appropriate for this series which you have started. I have not known Sneha for a very long time. I started getting to know her once the doors of Foxy opened to India, once we had these WhatsApps and the Facebook groups coming up, and we started intermingling with each other probably every day. That is when I got to know her. And what I know of her is, besides her talent, besides her education, besides her, intelligence and what all, I know her as a very immaculate person. I have never ever seen one pleat of her sari here or there, one pleat of her hair here or there. We may seem so unruly at times, but this girl is always absolutely spick and span and proper. My father used to say, if you see a woman with her sari 1 inch above the heel, she's a doctor. So here is one doctor who ties her sari, who wears absolutely appropriate. She's so appropriate. So congratulations for what you are, Sneha. I think you are one of the best, and you deserve to be the vice president of the West. And I congratulate you for this series. I congratulate you for all your endeavors. And you have chosen a very able partner with you, Monica, to lead this series with you. I'm sure both of you are going to do extremely well in this. Thank you very much. Thank you very much. And a very happy Women's Day to all of you. And to the men who are married to the women.
Thank you,
Thank you so much, Madam. Trikala, can we have Dr. Himanshu's CV? A very good evening, Dr. Himanshu, and it's a honor to have you on this platform. Dr. Himanshu is a consultant at Srijan Fertility Clinic, Patna. As I have already said, he's the secretary of Bihar IFS and president of Fetal Medicine Committee, Patna Obstetrics Gynec Society. And he has some accolades to his credit. The first IVF baby of ISAR in 2003, and he's won various FOXY awards at national level, running training programs accredited by FOXY, ICOG, and IFS. So over to you for your words of guidance, Dr. Himanshu. We are very happy to listen to you.
Thank you so much, Dr. Sneha. It's actually it was a surprise to be a guest of honor with so many esteemed, like our teachers and teachers of teachers with us. Dr. Narendra Malhotra is there, a past president of FOXY. Dr. Sonia Malik, whose wisdom nobody can fathom how good she is. And Dr. Amit Patki, our friend, now President ISAR, is there. And our president-elect, Dr. Parag, is there. And I cannot forget about Dr. Monica. She is also a very good friend, long-lasting. I know her since last 20 years. And the work that they have been doing since last 20 years, which I've seen presenting papers at Esri and things like that. So, Dr. Sneha, you've got a very good team with you, with Dr. Monica and Dr. Manisha with you. And this thing that you have started, the benchmarking series, and you've started with the very basic things. So that is very important. People so many times go to such hi-fi things without following the basic things. So to start this benchmark series by benchmarking the basics is very important. And in future series, I hope gradually the topics will be covered. And if the basics are good, then advanced things will also get covered very fine. So I would not take much time from this thing, and I wish you my best wishes and all my cooperation for your candidature for the Vice President of FOXY for next year. So thank you, ma'am, and my best wishes, and keep going on with this program.
Thank you so much. Thank you. Tekla, can we have Madam Jemkanan Sibi, please? So here is my mentor, my advisor, my guru, whatever I can say to you, madam. You are blessing me always, guiding me and hand-holding me almost. So it's my pride and privilege to have you here, madam. All of you know, madam was a vice president of FOXY in 2018, and what an meritorious career she has had right from her UG and PG days. We will not spend time in that. I would just say that madam is such an illustrious person, and she has, I'm sure recently she has received the RCOG award also, and all of you know what distinguished service distinguished service to the community she is doing. I'm so impressed, even with your spirituality, madam. So I'll be very happy to have your blessings, and over to you, Madam Jemkanan.
Thank you, Sneha. I have been known to you for more than a decade. And I always feel the youngsters to spring up in the cadre. And I expected this thing for you to come up. And I am very sure that you are going to get it done this time when you are going for your vice president. And more than that, your topic of choice today is this insight into infertility. This is a topic which is really sprouting up a lot. Why was not infertility there in the last this century? It was there, but it is really more due to so many environmental and other factors. And as it has sprang up, you are also going to spring up more and more and lead to the highest position in FOXY, and more so do your best to this Obstetricians and Gynecological Society, to the patient interested. I greet this meeting a great success. Thank you very much for this opportunity.
Thank you so much for your precious words, madam, and for your blessings as well. Thank you so much. And with this, I hand over the mic to you, Monica, you can take the proceedings forward.
Thank you, Dr. Sneha Bihar. for setting, the program in a way that we can now start with the talks. And for the session one, we have two speakers and we have three chairpersons. First, I will invite Dr. Parag Beniwale, sir. Sir is chairperson-elect ICOG. Sir is a senior consultant of OBGY in Pune. And whenever we see Dr. Parag Biniwale, we get such a sense of positivity. And Sir is equally charming inside as he's outside, that I can say. And recently I was not keeping very good health. And he, asked every time I called him, he used to ask me, Monica, how you're feeling? Sir, I'm so grateful for your concern. Sir has been a PG teacher, unit head,
Monica,
chair.
that's fine. Don't waste your time reading that.
So
Let's move ahead with the program.
lots of medals in his star-studded career, and we are very grateful to have you as chairperson today, sir.
Thank you, Monica, for the kind words.
Next, I would like to invite for session one my dear friend, Dr. Seema Pandey. And has she joined, Dr. Manisha?
Not yet, ma'am.
Okay, so we can, just speak about her a little later. The third chairperson for the first session is Dr. Lavanya Kiran, again, a very dear friend of mine, and she has joined just now. Dr. Lavanya, from what I went through her CV before this session started, and I can sense that she's a very keen endoscopic and robotic surgery, which many people are not doing. So she has mastered that. She's working as a lead consultant in a very uh, good setup of Bangalore, Kaveri Hospitals. It's a group of hospitals, and she's also visiting surgeon at Cloud9. Now, she has received so many awards in the field of medicine, science, commerce, as well as social work. So I was
I'm also okay to skip
list.
my CV and
So,
love
Lavanya,
to listen
so
to
if there is,
all
if
of
there
you.
is, so Lavanya, what is that one achievement you're really proud of and which you would like no MOC to miss? Because I find every achievement so vitally important. What is one achievement which you're really proud of?
I'm proud about being a robotic surgeon and helping all our fertility patients. And I think we all are equally passionate about helping our women and go home with that bundle of joy in our own capacities.
Thank you, Dr. Lavanya. That's
We have Madam doing so much of work and having a wonderful team. I think we are all here to support her. So
thank you so much. So, Dr. Parag, could you please introduce our speaker for the first session?
Thank you, Monica. And I bring greetings from Pune, and it's indeed a pleasure to be sitting here with the doyens of infertility, I should say. Pleasure to see very dear friend, Dr. Sanjeeva Reddy, and of course, Himanshu, and a very, very, very dear friend, I should say, Dr. Sonia Malik, who's been a mentor, a guide, and a critic as well. Right. So thank you, Dr. Sonia, for being that. We move ahead with the first talk, and that would be delivered by Dr. Sneha Boyar. It's very difficult to talk about a friend who's grown up with you. Sneha and I did a PG together, and we've seen each other grow. Sneha, we are really all our classmates are really proud of the work that you are doing, and we would certainly like to see you being there as the vice president of Foxy in the forthcoming elections. Monica has already given some introduction, so I'll request you to start your presentation, please.
Thank you so much. A very good evening to all of you. In fact, though I'm not an IVF person, that's the reason I think I always believe that I'm a grassroots worker, and that is why I start from the grassroots, and this is a part of that evaluation, counseling, evaluation of the infertile couple, and of course the counseling, which is so very important. So I take this opportunity to present in front of you a very basic talk, which actually the basic things are missed sometimes, and that is why maybe you need to really remind people. So amongst all the gathering of the IVF specialists, I start with this basic talk. So what is infertility? Right from this, we have to start, because the patient or the couple who is sitting in front of you they actually need to know whether they are really infertile and when do you call them having infertility. So failure to conceive after 1 year of unprotected regular intercourse, that is when you label the couple as infertile, and the incidence being around 10 to 15%. Now, the diagnostic evaluation of the infertility is indicated for women who fail to achieve successful pregnancy even after 12 months of regular unprotected intercourse. That is how we define. So around 85% of these couple who are, married and they are trying for pregnancy, they conceive within this time frame. But around 15% of these couples, they may not conceive, and that is where comes the need for evaluation. So what is the incidence as far as the male and female factors are concerned, and also the individual factors? So around 27% of these ovulatory dysfunction, 25% is male factor, 22% is tubal factors, and rest of the around 25% is the rest, that is endometriosis and other factors. 17%, a major chunk, is the unexplained factor, unexplained infertility. So basically, whenever a couple who is, seeking your help for conceiving, or maybe they have the diagnosis of infertility, when they are coming to you, counseling becomes a major challenge for you. Because right from history taking, you have to be really thorough, whether their marital history, the intercourse, the cycle regularity, everything you have to take into consideration. So counseling plays a major role here. Of course, when it is management, the investigations followed by treatment, that all of you know this. But the patient counseling is the most important, I would say the most neglected part many times. At least 20 to 30 minutes of counseling is needed uh, to explain to the patient or the couple what their problem is, what you're going to investigate and evaluate, to put them on a right track. Because, and it's not only there, put them on right track, but it's, to develop the bonding between them and, the long-term relationship, definitely. So the long-term compliance of the patient is a key to success of management for any kind, that for that matter. So both husband and wife, either they should be counseled or evaluated separately and then together. That is how stepwise we can do it. The counseling should be a combination of reality, honesty, and positivity. It shouldn't be everything rosy, because sometimes when you cannot fulfill their desire, you cannot fulfill their expectations, then they land up into frustration, and you also land up into negativity, and the litigation happens there. So that is why reality is very important. So you have to explain them what is the roadmap of getting the pregnancy, natural intercourse for 1 year, then what investigations they have to go through. You have to actually treat the cause, if any, like I've already said that the menstrual cycles may not be regular, the ovulation may not be there, the happening, and in this situation, you have to explain to them how the treatment will go, whether you will regularize the menstrual cycle, ovulation induction will happen, and then whether you will try for IUI. Whether you will try for IUI for 3 cycles, 6 cycles, and then you go for IVF surrogacy, and if at all everything fails, for adoption. So you have to be honest to these couples. Most of these couples, they do conceive within the time frame with proper scientific treatment. But some of these, may fail to conceive, and these are the ones are very difficult to tackle. So you have to show little empathy towards the couple, and with realistic approach, you can, convince them, tell them that over a period of time, you may succeed to get pregnancy, and you have to be just give patience and be positive, be on the right track. Now you have to face so many frequently asked questions during this counseling session, that doctor, whatever you are prescribing, we are taking all the medications, whatever investigations you have advised, we are doing, then why is she not conceiving on medicines alone? So if she's not ovulating, you're giving the highest dose of gonadotropin. If she has landed, but then in spite of the highest dose of gonadotropin, because I'm sure many of you have experienced it, that you are just increasing the dose of gonadotropins, and at one point where she doesn't show any developing follicle, then that is a very frustrating point or frustrating moment for both of you, I would say. So if she has landed up into premature ovarian failure, or if she has ovarian insensitivity, in spite of ovulating, if she doesn't conceive, maybe she can have bilateral tubal blockade, azoospermia, severe oligozoospermia, teratoastenospermia can be again the causes. But in spite of everything being normal, if she doesn't conceive, then of course you land up into what is called as unexplained infertility, which is so difficult to explain. So what are the indications for IVF? How would you counsel your patients? Definitely failed 6 IUI cycles. I'm sure the IVF specialist will defer to this, maybe 3 IUI cycles or so. Bilateral tubal block, where, which could not be corrected even after surgical interventions, unexplained infertility, and when all other measures have failed, or even when you plan, you have the gametes of both the partners normal, but there's a problem with the uterus, and that is where you may think of going for surrogacy. So naturally, these are the situations where you have to resort to IVF. So while counseling, you have to answer each and every question very patiently. So no question is stupid. You can't say that, because counseling and discussion is going to improve the doctor-patient relationship. Definitely for conception, naturally your patients, they're not medicos. They will not have, they may not have any knowledge as far as the conception is concerned. So even though majority of these patients nowadays, because of Google and all, they have much scientific knowledge, you may have to explain them what is the ovulatory period or what is the fertile period, and when should they have timely intercourse, means what. So what is the correct position? Here, of course, you have to say that there's no correct position for conception. It's only penetration that is required, penetration and ejaculation of the semen that is required. Is daily sex required to become pregnant? That also you have to explain, because these are the questions I'm sure all of you are also required to answer to the patients. So sperm remains alive for 48 to 72 hours. So maybe alternate date sexual intercourse should suffice. That is how you have to reply to the patient patiently. So how do you go for the evaluation of infertile couple? I've already said the history and detailed physical examination, test for ovulation, assessment of ovarian reserve, semen analysis, and of course, though outdated, I have just mentioned the sperm cervical mucus interaction, the postcoital test, detection of uterine abnormalities, tubal patency test, and detection of the peritoneal, that is the tuboperitoneal factors. In the history, the menstrual history, of course, the details I would not go into. The duration of infertility definitely has an impact on this ways of, going ahead. Results of the previous evaluation and treatment, obstetric history, whether she had conceived initially or this is her totally, the nullipara. She's contraception used, if any, and the effect of it on the fertility, coital act frequency, vaginismus, dyspareunia, etc. Because I have already said everything may be normal, but there may be just non-utilization, non-consummation of marriage. That is also possible. Past surgery, serious illnesses, pelvic inflammatory diseases, and sexually transmitted infections, thyroid dysfunctions, galactorrhea, hirsutism, family history of congenital malformation, chromosomal aberrations, mental retardation, early menopause, and reproductive failures. These also we have to take into consideration. So what examination, general examination of course, the weight has a very a significant impact, that is BMI, and the vitals, thyroid, you have to examine the goiter, look for breast secretion, signs of androgen excess. The local examinations, vagina and cervix, may be whether single, double, septate, whether there is vertical or transverse septum in the vagina, The uterine position, shape, size, mobility, tenderness, and the adnexia and cul-de-sac nodulae. All these things are very, very important. May whatever the gadgets of the technology has progressed to such an extent, even we have reached the stage of AI, but the history and detailed physical examination has its own place. Now, the indicators of ovulation, definitely we do have this serial follicle monitoring or ovulation studies, but in spite of all this, you can, it may not be feasible for that couple to come all the way daily or alternate date for this. And that is how the menstrual history, basal body temperature, serial follicular study by transvaginal sonography, serum progesterone levels if available, but if not, the urinary LH and even the proprietary tests which are available for ovulation kits we can use. Exclusion of the male factor, as I have already said, this is the semen parameters according to WHO 2010, and the volume of more than 1.5 ml, count of 15 million per ml or more, motility of more than 40%, liquefaction in 30 to 60 minutes, 40% or more normal forms, and pH of 7.2 to 7.8, leukocyte density of less than 1 million per 1 million per ml. So this is what is taken as normal. Cervical factor, I will not cover into details because this is almost obsolete, I would say, though at some centers it is done, and you have to do this immediate pre-ovulatory 12 to 14th day with 48 hours of abstinence. This is what it is described here, but it has got a limited yield of useful information, and so this is not routinely done nowadays. The hormonal assays, day 3 serum FSH, LH, estradiol, T3, T4, TSH, prolactin, and AMH has its own place. Assessment of ovarian reserve. The concept of ovarian reserve, definitely the number, function, and quality of the remaining oocytes. So the antral follicle count and AMH. I won't say single as individual, but both in combination definitely can give you an idea about ovarian reserve. Diminished ovarian reserve describes women of reproductive age group having regular menses who respond to ovarian stimulation, and it is reduced than that of the normal counterpart. So what are the tests for ovarian reserve? The FSH and estradiol, clomiphene citrate challenge test, of course, the antral follicle count and AMH. What are the indicators, rather, what are the indicators of diminished ovarian reserve? Age above 35 years, family history of early menopause, oophorectomy, either surgical or radiation or chemotherapy-induced ovarian, the menopause, which is iatrogenic, unexplained infertility, poor response to gonadotropins. However, poor results with any of these tests do not necessarily imply inability to conceive. That is the bottom line. And we don't have to comment very drastically that it is impossible to conceive with this. Sometimes you may get it as a magic. Now, so you have to really keep a watch on, you have to see that the results are from a standard lab. And of course, you need to confirm before making any statement. So these are the investigations to evaluate the uterus and vagina, uterus, cervix, and vagina. So ultrasonography, 2D, 3D, 4D, color Doppler, SIS, sonohystrography or saline infusion sonography, MRI, and hysteroscopy. HSG, though it's an old test, it still has its own place even today. It gives you an documentation that which tube is blocked at what level. Suppose you want to plan for tuboplasty subsequently. Saline infusion sonography is a very useful investigation, especially for an intracavitary lesion. Hysterolaparoscopy is the gold standard of treatment and management. It can be diagnostic as well as therapeutic simultaneously, and definitely you can go for tubal cannulation and operative procedure at that time. So if you have a patient of, for the tubal function, how do you comment? That compromised tubal function can occur after external injury. So even though you find that externally the tubes are morphologically normal, but its function can be abnormal because of the loss of integrity, and that is because of the damage the tube has suffered So it's not only the external appearance, but its function also you have to think about. So I will just keep these hormones which are used, but this is, if at all the patient asks you that what are these hormones, and you may have to explain to them what is first generation, second generation, and third generation gonadotropins. So what is the difference between the various preparations? So I will just quickly run through all these slides. That ovarian stimulation protocols, all of you are very well versed, but you have to just explain to them that over the period of time how this is evolving. That 80 to 90, it was only HMG. 90 to 95 it was ultra FSH, and 95 onwards it is FSH HP, but 2000 till then it is recombinant FSH. So this is how you have to explain to the patient. Ovarian stimulation protocols, I'm sure all of you must have been, teaching all your students, but this is just to complete the presentation I have just included here. The pituitary down regulation, the long down regulation protocol, the short ones and the ultra short ones. The very purpose of this, including of these slides in this presentation, is the patient can question you on any point, and you should be patient enough to reply to the patient very systematically, scientifically, that how you have to go. If at all you plan for a IVF procedure, what are the IVF procedures available, and what does IVF or test tube baby means, that you have to actually tell them that when you consume these medications, it acts on the ovary and the follicular development you have to actually monitor, and when the dominant follicles are seen, then you have to actually go for the ovum pickup, and how this is how you have to retrieve the ovum, and then you have to go for preparation of the sperm, what is called a swim up method, and the density gradient method. So the whole idea is to get grade 3 and grade 4 good quality sperm. That is what we can explain them, that excluding all the debris and the bacteria, everything. And then of course the test tube baby, that means you have the 4 methods, the plain simple IVF, then ICSI, MC and ICSI, and laser assisted hatching. So this is how you incubate these gametes, and this is how the fertilization takes place, and then the 2-stage, 4-stage, and 16-stage cellular divisions, and then how you go for embryo transfer. That is what you should be able to explain to the patient. And I'm sure after explaining everything, when they're satisfied, and they understand all the procedures, the pros and cons, definitely you have to I mean they will agree to it more, and they will be very compliant with your management. So I think that is all from my side as far as the evaluation and counseling of the infertile couple is concerned. And I hope I have done justice to this short presentation, which is a very basic one to start with. I'm sure all the speakers who are the stalwarts in the field will go ahead further with the advancement of the management. I just take this opportunity to seek your support to my candidature as Foxy Vice President from West Zone. And the elections are in August. Definitely, I'll be requesting you on some more occasions. And thank you so much for all of your patient listening. And thank you, chairpersons, for being here. Thank you once again.
Thank you, ma'am. I think it was really a wonderful talk. Only thing I don't agree with your talk is that you said none of my infertility friends agree. I think we agree with everything that you have said, because I think it's not easy. In this short span, you covered it so well. And I don't think you left any point. And, though you called it the basic talk, I think it's the most important thing, because for the evaluation, investigations, and you also touched upon the semen preparation, the protocols. I think this is what is the most important crux of the success for be it the fertility doctors or even the common gynecologists. I think you touched upon every importance of the history, and I think we should never forget our history. Though at our fertility centers, we see a lot of people who've already gone through different cycles come in. When we take a detailed history, small things like tubal evaluation is not done. They would be doing so many IUI. Protocols are started on 7th, 8th day. No basic baseline scans are done. So simple history, I think, makes a lot of difference. And I think that is what helps us give them a better chance to conceive and go home with the bundle of joy. I think really you've raised the standards and made the benchmark much more higher, ma'am. All the best. We are with you, ma'am. Thank you so much for this wonderful talk.
Thank you so much, Dr. Lavanya, for those wonderful comments, and thank you for your best wishes. Thank you.
Thank you,
Monica.
Dr. Lavanya. I think Dr. Seema Pandey has joined us. So can I have her CV, please?
Yes.
Chitra.
Hello, Dr. Bebu. Hi, Bebu.
Hello, ma'am.
Welcome.
Hello.
So
We can't hear you.
Please
Seema
unmute.
to
Please
take-
unmute, Seema.
Hi, hi, Dr. Sneha. Nice listening to you. It was a very crisp talk and very nice. I loved your slides.
Thank
So
you.
I just speak a few words about Dr. Seema Pandey. Besides being a very, very dear friend, and we agree and we disagree and we argue and then we make up. And Seema is, currently the librarian of ISAR. She has started Azamgarh Obsgynae Society. She has been so active and so hardworking in ISAR. I've seen her grow. She's also a member of ISPAT. Her passion is she goes to the community and teaches. I've seen her, live on Facebook teaching the girls and, going to schools and doing the camps. So it's not like she's just preaching, she's practicing that also. And her awards and achievements go on and on. So, Dr. Seema, can you please introduce our second speaker for session 1?
Thank you, dear
Monica,
Monica.
before Seema
Such a
speaks,
kind-
just one comment. Sorry, Seema. She's forgotten to write that she's a governing council member of ICAG.
Yes,
Very
नहीं,
conveniently forgotten.
no. ये लोग पुराना स्लाइड लेके सीवी वाला घूम रहे हैं अभी तक और मैंने पिछली बार खुद से इंट्रोड्यूस करके बताया था कि आई एम आईसीयूजी गवर्निंग काउंसिल मेंबर एंड द सेम स्लाइड इज सर्कुलेटिंग एवरीवेयर पर and tonight I will make it sure that I correct it.
Yes. And everywhere you post your updated CV now.
Yes, because I asked someone to just give my CV and they just they are forwarding the old one.
So, Dr. Seema, our second speaker is Dr. Sanjeeva Reddy. Could you
Yes.
introduce him, please?
Can I have his slides, please? And this is really a pleasure and real nice to introduce Dr. N. Sanjeeva Reddy. Sir is Professor, Department of Reproductive Medicine and Surgery, Sri Ramachandra Institute of Higher Education and Research, Chennai. And it is first department and university college. He has the credit to start first super specialty course, MCH in reproductive medicine and surgery course in India. And that is really commendable. Sir has received Dr. B.C. Roy National Award 2015 as eminent medical teacher presented by President of India. Sir is has distinguished faculty award to his credit 2020 Shri Hair Chennai. Champion of ESAR Award 2020, IVF Icon Award, Asia GC.
Please, that's enough, madam. Please.
Apart
you
from that, sir is specialist board member reproductive medicine, expert member to prepare syllabus for fellowship courses. Sir is president TAPESAR and past president OGSSI. I welcome you, sir. Over to you, sir.
Thank you, madam, for your kind introduction. At the outset, I would like to thank the program coordinator, Dr. Sneha Buyar, for inviting me to be here and share some of my thoughts, and for the wonderful coordination by Dr. Monica Singh. Thank you. Today's my topic is the impact of maternal age on fertility and risks in the offspring. As we all know, female fertility decreases with advanced age, because women are born with a definite number of oocytes, and its steady and continuous decline of these follicles, resulting in the decrease of ovarian reserve after birth. Men generally retain the ability to generate sperm over their lifetime. No age-related time limit on reproductive potential. What is the impact of maternal age on fertility is well established. Advance in maternal age is associated with reduced rates of conception over 40 years of age. This is because of there is increased risk of implantation failure, miscarriage secondary to oocyte aneuploidy. Even if the patient conceives, there will be obstetric and perinatal complications. That's why there will be decreased fertility and other things. There is relatively little evidence exists on the how advanced paternal age can affect fertility in general. What is its effect of the paternal age on health of the offspring if they deliver? Over the past 4 decades, why we have to discuss about this? Now we have to interested about the paternal age. Over the past 4 decades, fathers age less than 30 years has been decreased by 27%. Fathers age 30 to 34 years increased by 15%, and the age group 35 to 49 years increased by 50 to 63%. What is the reason for this increasing paternal age and there is a decreasing increasing age of these fathers? There is change in the societal trends led to couples having children at older ages. These include educational, career-related commitments, desire for financial security, increased life expectancy, increased use of contraceptives, and availability of ERT treatment. They will think anytime, any age we can go and we can have baby. So I'm going to discuss under the following headings: hormonal testicular function changes, semen analysis and sperm quality, potential mechanisms leading to problems, pregnancy success rates in these patients, whether there is an effect is there on the offspring, whether there are any treatments available for these things. Let's take the testicular function. Alterations in the hypothalamo-pituitary testicular axis disrupt the average production and control of many reproductive hormones, leading to atrophy of the testes as people ages. The most frequent clinically relevant changes in male aging is increased FSH levels and decreased testosterone levels. Testicles of older fathers tend to have fewer Leydig cells. The average number of Leydig cells dropped by 50% in men aged between 50 to 76. And if you see the semen analysis, aged patient will be associated with a decrease in the semen volume, total sperm count, sperm motility, and also sperm morphology. At the same time, there will be increase in the DNA fragmentation. Overall, the most consistent findings are negative correlation with semen volume and motility, positive correlation with the DNA fragmentation. If you take the DNA integrity, several studies that report increased sperm DNA fragmentation with the paternal age. Elevated DNA fragmentation leads to reduced fertilization, cleavage formation, blastulation, and the ART also decreases the pregnancy rate. One mechanism to explain the relationship between DNA fragmentation and age is it leads to increased oxidative stress generated by the accumulation of reactive oxygen species in spermatozoa. And what the evidence says. Here, if you take, there is many studies done from 2015 to 2021, what I'm present. There are decreased semen volume, decreased count, decreased concentration, decreased motility, decreased morphology, and vitality. At the same time, there will be increased DF5. And when it takes these patients, if you allow them to have natural pregnancy, what is the result? API increases the risk of natural reproductive failure in 2 important areas. One is infertility, second one is miscarriage. API is associated with a longer time to pregnancy and subfertility. Dawson et al. Found that 18 to 28% of men aged between 35 to 40 years were unable to achieve natural pregnancy within 12 cycles. Posolotto et al. Showed that the probability of conception in more than 12 months doubled from 8% to 15%. when comparing less than 25 years age and more than 35 years age in men. So there is taking longer time for the patient to conceive. And what is its effect? There will be increased miscarriage rate in these patients. When the age increases, there will be increased chance of miscarriage also in these patients. Suppose if you do the IUI for these patients with the paternal age is high, what is the effect? Belloc et al. Evaluated more than 17,000 IUI cycles and found that APA, that is more than 45, was associated with poorer pregnancy rate and increased miscarriage rates. Osumi et al. Analyzed 1,576 IUI cycles in women under 40 years after adjusting for compounding factors was not associated with pregnancy or live birth rates. Debaker concluded that paternal age was synergistic negative effects on IUI success rate when the female partner is older than 35 years. So there is different ways. Some papers they are telling the pregnancy rate is not affected. Many papers are telling the pregnancy rate definitely will affect. When it takes the ART, the influence of APA on ART outcomes is highly controversial. Many studies found APA has a negative effect on the success rates of ART. Others found it is insignificant. In IVF and the ICSI, the impact of APA on fertility, pregnancy rates remain unclear. Cumulative pregnancy rate and fertility rates decrease in men aged more than 50 years compared with less than 40 years. Men aged 25 to 30 years had fertilization rate is higher, that is around more than 85%, which decreased to 46% among men if they are more than 55 years. What the literature says, here what they have done is, they have compared each age group also, less than 35, more than 35, less than 40, more than 40, and they have taken the autologous oocytes and also donor oocytes they have taken, and the male partner's age is higher. So what they say is, in autologous cycles, paternal age less than 35 years, less than 40 years, less than 45 years was associated with a statistically significant greater odds of pregnancy and life rate than paternal age of more than 35, more than 40, more than 45 years respectively. There is statistically significant greater odds of loss if paternal age was less than 40 years when compared with more than 40 years. A lower miscarriage rate also if the age is less than 40 years of the male. And when applying a paternal age cutoff of 50 years, a statistically significant detrimental effect of increased age in donor cycles was demonstrated when analyzing the number of cleavage stage embryos, blastocyst rates, and miscarriage rates were seen. Higher fertilization was achieved using ICSI. In older patients, when they compared with IVF and ICSI, ICSI is having better fertilization rates when compared with the IVF. Older men have poorer fertilization rate following ICSI also. So in older patients themselves, if you see, it is less when compared. Suppose it is more than 40, around 40 years, the fertilization is 65%. With more than 50, it is dropping to 56%. One study found there is 0.3% decrease in fertilization rate for each additional year of paternal age. When it is increasing, 0.3% is decreasing for every year. And embryo development quality, if you see, sperm DNA may be associated with embryo development. So the poorer quality of sperm DNA in APA may result in poorer embryo development outcomes. Adverse effects of increasing male age on blastocyst formation may be related to impairment in male genome activation that occurs at cleavage stage. Here one thing, the cleavage stage embryos are not affected, but blastocyst formation is affected in older males. Implantation rate, some have found an inverse relationship between paternal age and embryo implantation rates. One study finds a 3.1% decrease in implantation rate for every additional year of paternal age. There will be significantly worse clinical pregnancy in men more than 50 years old in comparison with less than 40 years. With the donor oocyte, implantation rate was decreased when paternal age was more than 35 years. In another study, when the paternal age was more than 60 years, the implantation decreased from 43% to 22%. And pregnancy rate also, if you take, Thoreau et al. Found IVF cycles using ICSI and found rates of clinical pregnancy were lower, rates of embryo transfer cancellation higher in older patients more than 40 years. Several other studies have found no association between paternal age and pregnancy rate, including donor oocytes after adjusting for compound factors. They thought most of the time these people also older, a wife also will be older. That's why the pregnancy rate is decreasing. In some of the studies, they are telling there is no effect at all. And live birth, several studies have found significant decrease in rates of live birth with increasing paternal age. With IVF cycles, there will be a 12% decrease also of live birth for every year, increase in year. And idiopathic infertility also, there will 4.1 decrease odds of live birth for every year of age, if the male patient age is more than 50 years. And miscarriage rates, couples with idiopathic infertility, a 4.5% increase in miscarriage rate for every increased year of male age. Infertile population, pregnancy conceived by men over 45 were 87% more likely to end in miscarriage when compared to the younger age. There have also been several studies that have found there is no relationship between AP and miscarriage rate, including donor oocyte ICSI cycles. When it comes to is there any effect on the genetic and epigenetic changes? Numerous such studies have shown that paternal age affects various biological processes such as oxidative stress, DNA mutations, chromosomal abnormalities, microsome deletions. So this can lead to chromosomal abnormalities, Y chromosome microdeletions, telomere elongation, oxidative stress, DNA fragmentation, gene mutation, centromere aberrations, microRNA changes. Because of these factors, male fertility decreases with age. Next is paternal age and chromosome and genetic anomalies of the offspring. When it comes, we'll see each one separately. Trisomy 21, that is aneuploidy. Garcia Pereira found a significantly increased rate of aneuploidy, such as trisomy 13, 18, 21 in sperm and embryos from men over 50 years of age. No matter, but when compared with maternal age, the paternal age, it is only 10% of babies will have trisomy 21. A recent retrospective study of about 3,000 embryos from an oocyte donation program found no correlation between paternal age and aneuploid rates. So definitely we cannot say, but there is increase in the aneuploid rate. Next, when it comes to the other anomalies like achondroplasia and Apert syndrome, achondroplasia is the consequence of FGFR3 mutation. The link with the paternal is well established. Men, if the man's age is 50 to 54 years, there are 12 times more likely to have a child with achondroplasia than men of younger age. Apert syndrome is characterized by craniosynostosis due to a mutation of FGFR2. The risk was estimated to be 9.5 times higher for fathers older than 50 years. Next is whether there is increased psychiatric and neural development disorders to the offspring born to this advanced paternal age. Autism risk was estimated to be 5.75 times higher for men over 40 years of age. The risk increased by about 21% for every 10 additional years of paternal age. And there will be a strong link between children's schizophrenia and also paternal age. This risk was estimated to be 1.66 times higher for fathers more than 50 years. Next, the risk of developmental disorders like bipolar disorder for children has been assessed in 8 studies with controversial results. One study concluded that there was a U-shaped correlation. 2 studies found a significant correlation with 1.37 times higher risk when the father was more than 55 years. Concerning the obsessive compulsive disorders and ADHD, one study found a monotonic link between paternal age and OCD. one study found U-shaped relation between paternal age and AH3 gene. There is an increased chance for major depressive episodes also in these children. Next, AP was not associated with risk of epilepsy, but in these children, it is not related to the advanced paternal age. There is controversial results have been published concerning children's intelligence quotients. There will be some studies are suggesting this is older age protective. Some they are telling it is decreased. This is summary of all the studies in other countries also, like all many countries they have done. So these are the findings they have given. It is definitely affecting. The type, is there any way we can correct these problems? Lifestyle modification, it optimizes the health and minimizes the toxins so that the semen, other things will improve quality. Antioxidants rich food reduces the oxidative stress related to damage, and medical management, oral PDE5 inhibitors, intracavernosal injection, enhance erectile dysfunction, because in the older age patient, they will have erectile dysfunction. Whenever there is antimicrobials, you can give to treat infection to improve sperm parameters. Antioxidants you can give to reduce the oxidative stress related damage. Alpha adrenaline again is to treat retrograde ejaculation if it is there. Surgery, there is varicocele to optimize the production of zinc in patients with varicocele. Prenal prosthesis, if it is not responding to medical treatment, then finally we can go for the prenal prosthesis. Allow penetrative sex in men with erectile dysfunction. Next is sperm extraction, allow for assisted reproduction in men with oligoazoospermia or elevated DNA fragmentation index also. If you take from the test, sometimes the quality of the embryos will be good. In summary, there will be decreased sperm quality of the semen volume, count, progressive motility, sperm morphology, acrosome reaction, fertilization capacity, and the DNA integrity also it will be low. When it comes to the adverse reproductive outcome, there will be decreased assisted pregnancy. Even if you're an IVF, there will be increased chance for pregnancy loss. There is chance for increased premature birth, and stillbirth rate also is very high, and decreased birth weight in these patients if they are advanced pregnant. And the offspring, if you take, there will be increased schizophrenia, bipolar disorders, autism, childhood cancer, and other disorders like achondroplasia, other things. Technology outcomes from offspring health, a systematic review recently published. So here they analyzed 111 articles selected after screening, PubMed all articles. A strong correlation was highlighted between advanced paternal age and a decrease of some sperm parameters like semen volume and sperm motility and infant morbidity, increased incidence of achondroplasia and Apert syndrome. The impact on pregnancy and fetal aneuploid rate is more controversial. No association was found with spontaneous abortion rates. The conclusion is scientific parameters should be explained to older patients, parents undergoing ART. So any patient with advanced age, if they comes, we have to counsel them about and tell about this thing. Definitely we cannot say, but there is increased chance. For countries that discuss a limit on paternal age for access to ART, they are deciding this much age like that. They should debate before taking decisions on this. In conclusion, APA is associated with decreased sperm fertility, frequently linked to decreased semen volume and sperm motility. APA does not seem to be correlated with the spontaneous miscarriage rate. The frequency of some genetic autosomal dominant diseases and some neurodevelopmental disorders higher in children of older fathers. They seem to be linked to paternal age, even if the underlying mechanisms are not determined, and there are many confounding factors. The scientific parameters should be explained to older parents undergoing ART, and for countries that discuss a limit on paternal age for access to ART, APA, just like advanced maternal age, is associated with reduced fertility and poor health effects in offspring. Significant research efforts have uncovered some of the genetic, environmental, and disease factors contributing to age-related male infertility. This progress has, in turn, led to the development of strategies to improve or restored fertility in older men, such as the hormonal treatment of hypogonadism and the use of antioxidant therapy to counteract ROS-induced DNA damage. These advancements in clinical management strategies for men with infertility are highly relevant in the modern age, where because of multiple socioeconomic factors, many couples are choosing to have children at older ages compared with previous generations. Clinicians are encouraged to familiarize themselves with the issues to facilitate fertility counseling for couples with older male partners. These are my references to prepare this talk. Thank you.
Thank you, Sanjeev sir. I really know why Sneha madam and her team, Dr. Monica, Dr. Manisha, has chosen a stalwart like you. Because other than a stalwart like you couldn't have justified because of the lack of evidences, though we know male factor contributes as much as a female factor, because of the limitations of the studies that is available. I think you've done great justice. I love the way you spoke about the HPT axis. I think that's very important, and you also threw light and you cleared the myth. That age is definitely a constraint, and people should start considering. I think it is help all the clinicians, the gynecologists who've logged in, to talk to them and help their male patients understand. I think it beautifully put across that natural conceptions come down despite the ART and the IUI procedures that we are offering, and it's easy for our patients to be counseling henceforth that how more of anomalies will be common with them, the DNA fragmentation, and inversely proportion to the abnormalities that will be coming up. Thank you so much, sir.
Oh, fantastic presentation, Sanjeeva. Each slide had a very important message. It was a pleasure listening to you. Thank you.
Yes, even I would just make a comment saying that, yes, first of all, thank you so much, sir, for accepting our invitation. And as you can see here that, we have just thought of, out of the box that we will have subjects which are least covered. And maybe the gynecologists who are practicing as infertilologists, they will definitely love to listen to this different topic because these are the situations you have to face in day-to-day practice. So wonderful presentation, wonderful slides, and you have done great job, sir. Thank you so much. It was a pleasure listening to you.
Thank you, madam.
Thank you, Dr. Sanjeeva, sir. And after this enlightening session, which had two brilliant talks by Dr. Sneha Bihar and Dr. Sanjeeva Reddy, we move to session 2. Before that, I would like to welcome Dr. Asha Bakshi, who has just joined us. Good evening, ma'am. And I would like to welcome Charmila, ma'am, who joined us. Thank you, ma'am, for joining. And I would like to say a warm hello to my dear friend, Leena. Thanks for joining, dear.
Thanks, welcome all of you.
Welcome you all. And we move to session 2. For conducting session 2, I invite my co-MOC, Dr. Manisha Jain, who is a treasurer of Bhopal Obsgyne Society, a very active member of FOXY, as well as she has played a huge role in the ISAR Bhopal conference and is always by my side in all my activities. Thank you, Manisha.
So much, Monica ma'am. And to begin with, I'd like to express my deepest gratitude to Sneha ma'am and Monica ma'am for making me part of this inaugural benchmark series, which is going to set its own benchmark. With this, all the great session, now we move on to the next session, which again have a great stalwarts speakers with us. And to chair the session, we have with us our respected Dr. Chamila Ayu ma'am, who despite being so senior and academic, she's so humble that for each single call and message, madam has been responding in within few minutes. I welcome you, ma'am. Madam is currently Vice President of FOXY. She is Vice President of Trichy Obsgyne Society, and she has held the post of Chairperson Clinical Research Committee, FOXY. She has been the ICOG Governing Council member, and she has been the National Coordinator of UNICEF, FOXY, MEDA FOXY program, ISAR Kurukul program, and she has been very much actively involved in very academic sessions of ICOG, WHO Southeast Asia, Menstrual Hygiene Program, PCOS Society, and many more. I welcome you, ma'am.
Thank you, Manisha. Thank you.
Next,
we can take up next chairperson. Kalyan is joining in a minute. So introduction.
Okay. So the next chairperson, can we have the slide of next chairperson, please? Yeah, the next chairperson today with us is Dr. Leena Patankar. Again, she is a very senior gynecologist and specialist. She is the director of Patankar Hospital and also has been the founder of the Genesis ART services. She has very many awards and prizes to her credit, especially the CS Stone Prize Award, and many oral presentations she has received prizes. I welcome you, ma'am. Should we proceed to, or should we wait for Dr. We can now.
Yeah. You can introduce Dr. Kalyan. I think if he will join by the time. But
Okay. The next chairperson, Dr. Kalyan Barmade, is again a very senior and very much hardworking and actively involved. Uh, this one, he is currently the secretary of IAG and chairperson of Infertility Committee AMOX. He has also held the position of chairperson Public Awareness Committee and has been associated with various organizations as various managing council member, IAG, Maharashtra Chapter SR, AMOX, IMA, Latur Orphan Society, and various very much actively involved in organizing various conferences, especially the AMOX 2022 at AMOX Aurangabad. I welcome Dr. Kalyan.
yes,
Over to chairpersons now.
welcome Dr. Kalyan.
Thank you so
ma'am.
much.
Thank you for such a nice introduction.
Thank you.
It's an honor to introduce the speaker for the second session after a wonderful first session with great speakers. It's always it's actually a prestige for us that we're able to introduce Dr. Nagori, sir, because we are all his students. He's mentored so many of us the protocols for IUI. And sir is going to talk on how to get the best results in intrauterine insemination. Sir is the director of the Dr. Nagori's Institute for Infertility and IVF at Ahmedabad, India. He's won the best paper at the World Congress of International Society for Ultrasound in Chicago. He's got the first stem cell pregnancy in India. He's one of the first ever Center of Excellence for the Ian Donald School of Ultrasound. Sir holds regular trainings in infertility, IVF, and ultrasound. And he also holds Gujarat University recognized fellowship programs in infertility and IVF, has published several papers in index journals, and has contributed and authored several books. Over to you, sir. We are eagerly waiting to hear your talk. Joe, it is always new things we get from your talk that is always useful for our practice also. Thank you so much.
Thank you. Thank you very much, madam, for the kind introduction. Chairpersons and all the organizers of this webinar, I will be discussing how to improve the IUI results. Normally, the IUI is blamed for getting a poor results, but I would like to highlight how IUI is important and how you can get an excellent results with IUI. When we discuss counseling, diagnostic workup, indication, stimulation protocol, monitoring, IUI technique, and luteal phase support. Counseling is very important. The most important thing, what I have found in my talk, that you must discuss what you are going to do with the patient in IUI. But the second most important thing, majority of the patients, they keep abstinence before the day of IUI. And that's why whenever they give a sample, the sample is very poor, particularly if you are asking from outside, then also the sample will be very poor. And the pregnancy does not occur when the patient leaves the treatment and the patient conceives spontaneously. So you have to counsel that there is no need of abstinence. You can keep the relation, sexual relation at any time, irrespective of the day of IUI. Second very important thing to emphasize is that the IUI is simply the one item in the whole menu. Most of the patients believe that they conceive because of IUI. So it's not IUI that gives the pregnancy, but there are so many things from indication, stimulation, monitoring, triggering, semen processing, insemination, and luteal support. When everything is in order, then you get the pregnancy. Even if you miss a single step, either monitoring, triggering, stimulation, if you miss a single step, you are wrong somewhere, then you don't get the pregnancy. Singleton live birth rate with one cycle of IVF is not significantly different than 3 cycles of controlled ovarian hyperstimulation plus IVI with FSH. I still remember in 2017, there was a conference in the Salzburg, and that conference was the revival of IUI because everybody was going for IVF, and then the European countries, they decided that we should come back to IUI rather than doing all the patients for IVF. And that was a wonderful conference. This was also one of the papers that the 3 months pregnancy rate is as equivalent to IVF. Now, how to optimize IUI, particularly when your selection is correct, stimulation should be done by the gonadotrophin, monitoring should be done by at least a Doppler, and optimum luteal phase support. And even if this patient does not conceive, then in 6 cycles, we'll consider as an IUI failure. But if you have not gone for gonadotropin, you have not gone for Doppler, it means I will consider it as a personal failure rather than the IUI failure. And that's why if IUI is to be done, it should be done properly. Otherwise, it should not be done at all. Diagnostic workup is very important, and the most important part is the tube-ovarian relation. Now, I would like to spend 2 minutes for it, that how the ovulation occurs. The ovaria fimbriaca is attached to the ovary from the tube. And at the time of ovulation, the ovaria fimbriaca contracts. And when it contracts, the fimbrial end completely covers the ovary. And after covering the ovary, the columnar epithelium, the ciliary movement starts, and that causes -1 millimeter mercury pressure, and that sucks the ova in. So it's not that the ova goes like a roller ball and enters the tube. That's a general belief. But it is the tube that takes on ova rather than the ova goes inside the tube. And that's why the tube-ovarian relations are very important. And particularly doesn't mean that you have to go for laparoscopy for each and every patient. I always tell that if the uterus is mobile in ultrasound, if the ovaries are mobile, and if the tubes are not seen, it means it's a normal patient. And that's why the endoscopy is not required. Only in a long-term cases only we'll go for endoscopy. Otherwise, you can straightway go for an IUI without endoscopy. But the tube-ovarian relations are very important for getting a pregnancy rate. And that's why we never do HSG or never do any other test particularly, and we rely mostly on the endoscopy only. So laparoscopy is always the gold standard for tubal ovulation. Routine ovarian reserve testing is not required. I'm very much surprised that whenever I get any patient of infertility, I have not seen a patient who has not undergone AMH. I don't understand for IUI why AMH is done. AMH is at all not required, even because you always get 2 to 3 follicles, even if the AMH, which is between 0.3 and 1, and you don't require multiple follicles in IUI, you require only 2 to 3 follicles, and that's why at least I never go for AMH to any patient. And I see the interfollicle count, and if I get 2 to 3 follicles, they are enough for me for IUI. And we always believe, the majority of us, that 35 years means poor fertility. It is not so. There are two groups of patients. The age more than 35 are with normal fertility, and age more than 35 with the poor fertility. So majority of the patients are having a normal fertility. Very few patients have a poor fertility, and they do conceive with IUI. So age more than 35 doesn't mean IVF. You can try definitely IUI to all these patients. And my being a tertiary center, majority I get always after 35 years of age. And still we get the very good success rate. Indications of IUI, unexplained infertility, is always the first, while that for IVF is always the last. And that's why many patients, it is everybody's experience that a lot of patients where the IVF has been done for unexplained infertility, and then after leaving the treatment, they may conceive spontaneously. And this, everybody must have come across this situation in their practice, that after the failure of doing everything, they conceive spontaneously, because these are the patients of unexplained infertility. And that's why the indication is very important. Unexplained infertility, more than 170 patients for more than 3 IVF or ICSI failure, conceived with IUI, approximately 70% were idiopathic infertility. And that's why I always tell that unexplained infertility, you must try IUI properly for 6 cycles. And if the patient does not conceive, then you should switch over to IVF to all these patients. So unexplained superovulation with IUI has got always the higher pregnancy rate than only superovulation also. Second is ovulatory dysfunction, a case of hypogonadotropic hypogonadism. Normally people always jump for IVF, but remember that here the fault is of ovulation. Try to correct the fault. Rest of the things are done by the nature. So this was also one of the patients with 5 IVF failure. They conceived with HMG plus estrogen plus IUI in the second cycle. So what I want to emphasize here, that the indication you must decide, and the indication should decide whether you would like to go for IUI or whether you would like to go for IVF. Irrespective of the years of infertility, I always consider that the indication is very important to decide whether you should go for IUI or should go for IVF. Now, this is the very important patient I would like to emphasize, that nobody tries to improve the count. Now, today in the era of IVF, everybody would like to go for IVF. Nobody wants to spend any month for improvement of the count. And this was the patient who came to me with 3 million count with 7 ICSI failure. And patient came for the 8th IVF to me, but I would have been stupid if I would have done the 8th IVF on this patient, because all 7 were done by the giants and pioneers of IVF in India. So I cannot do anything magic on this patient. But I always teach my students that try to find out the prescription of your colleague and try to find out what they have not done rather than what they have done. And I could see that nobody had improved the count to this patient. So I explained the patient that let us wait for 3 to 4 months, improve the count, and if you improve the count, then we would like to go for IUI. And this is Professor Ishidori's regime, that FSA thrice a week and HCG once a week. If it is given for 12 to 24 weeks, then you get excellent count. I've got plenty of such patients. And if you see the 2023 Journal of Human Reproduction and Fertility Study, there are a lot of articles where the FSH improves the count to and you can convert an IVF or ICSI into an IUI cycle or even the spontaneous abortion. And this was the patient who conceived spontaneously because the count had gone to 22 million after 2.5 years. So always try to improve the count, even for IVF, ICSI, even for TESA also. Nowadays, it is recommended that you should go for a HCG FSH combination, improve the intratesticular count, and then you can go for TESA or you can do the biopsy and you can get very good number of sperms. The motile sperm count, how much it should be? It should be between 0.8 to 5. But by and large, 1 million count will be enough for insemination. Post-was count should be 1 million. Immunological infertility, no role of prednisolone, only IUI is to be done to the patient. Mild and moderate degree of endometriosis, go for IUI. 3rd and 4th degree, always IVF. So I always tell that whenever the follicle develops on the side on which the tube is open, then and then you should do IUI. Otherwise, if the follicle develops on the other side, the chances of pregnancies are very less and you should not undergo IUI in these patients. HIV positive male, HIV negative female, go for IUI. There is no seroconversion either in the female or in the baby. Now, stimulation protocol is very important. I told you that the gonadotropin gives the highest results. And this is the standard paper of Professor Roy Ambach, that the low dose FSH over the first line of treatment and chances of pregnancies are always the double. So we always go with the gonadotropin cycle, and that increases the pregnancy rate. This is our chart that we always measure by ultrasound. We do the scoring system. This has already been published in the journals, and we do the scoring system. And according to the scoring system, we go for stimulation protocol, either IUI, IVF, or freezing protocol. And here we never had come across any patient of OHSS, or even the failure is also very less. So that's why scoring system will be very useful, and accordingly we stimulate the patient. Now, why to stimulate for IUI? Is it necessary? Yes. Because if you don't stimulate, the pregnancy rate is 8.4%. And if you stimulate that when there are 2, 3, 4 follicles, level of evidence is 1A, then you get 15%, almost double the pregnancy rate. And that's why you should stimulate the patient for getting a better pregnancy rate. We have found letrozole plus recombinant FSH, excellent combination. Day 3 to 7, you go for letrozole, and by the time day 7, the LH and FSH starts decreasing. You start recombinant FSH or highly purified FSH, 75 units every day for 3 to 5 days. And according to the sonography, once you develop a good follicle, you give HCG and you do IUI to this patient. So here the advantage is that the number of ampules will be less, the cost to the patient will be less. So instead of 3 cycles of IUI and 1 cycle of IVF, here you can go to 4 to 5 cycles of IUI with 1 expenditure of the 1 cycle of IVF. So it is very, it's not costly for the patient, and patient can afford the 3, 4 cycles of IUI with you. Now, the antagonist, the use of antagonist is that when you get 1 follicle, then you give HCG, do IUI. Instead of that, when you get 1 follicle of 16 to 18 millimeter and 2 other follicles are 10, 11 millimeter or 12 millimeter, you should give antagonist and try to wait till this follicle comes to about 16 to 18 millimeter. So we have already discussed that when the follicles are more than one, you get a better pregnancy rate. So here the antagonists are used to have an accumulation of 2 to 3 follicles, and then we get an excellent pregnancy rate by giving HCG and doing IUI to the patient. Now, triggering is always done by either recombinant HCG 250 or highly purified HCG can be given. But whenever there are multiple follicles on both the sides, the gynecologists are afraid because of OHSS. Don't be afraid of it. You have got a chance of leuprolide acetate or decapeptyl can be given to the patient, and they never cause OHSS. So decapeptyl or the leuprolide acetate can be given to the patient. That is 2 milligram. Should be given. Normally, it can be given 12 hours apart, but in majority of cases, we always give 2 cc simultaneously at the same time. Now, whenever you're given an agonist trigger, then you should give a luteal support, judicious luteal support, and you may give cabergoline. But we have found out that if you have given agonist trigger, then even the cabergoline is not required. We never give cabergoline because it never causes OHSS. Now, the only role of estradiol valeric, otherwise what we have found that people for the improvement of the endometrium, a lot of people give estradiol valeric in a non-ART patient. It is absolutely not required. Don't waste the money of the patient. Estradiol valeric is required only in one group, and that is whenever you are given agonist as a trigger, then and then for the luteal support, you should give estradiol valeric, otherwise it is not required. Now, you should have at least a color Doppler so that you measure the size of the follicle with vascularity 3/4 and RI between 0.5, 0.4 to 0.5 and PSV more than 10. These are the minimum requirement to get an excellent pregnancy rate in IUI cycle. And if you don't have a color Doppler, if you don't have a good machine, then you should be satisfied with your results and don't expect too much very good results with this. But if you have 3Ds, you can still improve the results. If you have 3D power Doppler, you can definitely improve the results. You can see the cumulus and accordingly. If you don't see the cumulus, you may not give HCG, you may not do IUI, particularly in if you have a 4D machine. So these are very important points where you can decide exactly when to do IUI to this patient. Same is for the endometrium. You should have an excellent parameters of an endometrium, particularly in vascularity in zone 3 and 4 when it is there, and then if you give HCG, you get excellent pregnancy rate. But if vascularity is not there, or if the follicle is not good, and if you give HCG, you do IUI, your results will be very poor. Now, particularly when you do a color Doppler, then your PSV of the follicle may be very high, and whenever it is very high, it is closer to rupture. So all the time, it is not necessary that you do IUI with 36 hours. If the PSV of the follicle is very high, then you do it after 12 hours, and then second IUI is done after 34 hours. So double IUI is indicated particularly when the PSV is very high. Then you should do double IUI. Otherwise, single IUI will be enough to all these patients. So when perifollicular PSV on the day of HCG is more than 20 centimeter per second, and perifollicular, then it is within normal range, RI is within normal range, then you can do IUI twice. Now, how many IUIs? If you go to any IVF conference, people will be it will be difficult for them to tell you that only 3 IUIs to be done, no other further IUIs should not be done. What the literature says, there are very limited studies for more than 9 cycles. And pregnancy rate after 6 cycles was 30% and after 9 cycles was 41%. If time is not an issue, and some couples should be offered 9 treatment cycles, especially when the age of the patient is less than 35 years of age. So 2 cycles of IUI at 38 to 39 years and 1 cycle, this is what the literature says. That after the age of 35 doesn't mean that you don't have to do IUI to this patient. I have a lot of patients. I don't have that much time that I can give the examples of the patients, but this definitely helps to get a good pregnancy rate. So what is the summary? Absolute minimum cycle should be 3, preferably 6 cycles. And if time is not an issue, and if the age of the patient is less than 35 years, then maximum 9 cycles should be tried. And this is by Custers. I think Custers had done the highest work in IUI in the literature. And you can go for IUI even for 9 cycles in the younger patients. National Institute of Healthcare also says that 6 cycles of IUI should be done. And the UK, the parliament passed a law that only expected management and then you should go for IVF. No IUI at all. But 96% of the gynecologists refused this. Now only 4% of the gynecologists accepted this. And that's why the parliament had to withdraw the law. And once again, the IUI is introduced in the UK. So IUI has definitely a place. Superiority of IUI about no treatment is proven, and IVF is not regarded as the first line of treatment, and so the IUI can give you very good results. Now, few tips regarding it: no antiseptics are applied in the vagina, nothing, no saline, nothing is to be applied in the vagina, and 0.5 to 0.7 ml we are taking, or maximum up to 1 ml. Now, generally, people always go for the Cusco speculum. I never go for it because in more than 30% of cases, we get difficulty in introducing the cannula. And from the very beginning of my practice, I always catch it with an Alice forceps, make the canal straight, and then we introduce the cannula inside. And I'm very happy to tell you that from 2014 onwards, lots of paper came that you must catch with an Alice forceps or with the tenaculum. So you require uterine contractions. So the pendulum has gone from this side to this side straight away. Formerly, people used to say that it should not excite the uterus and no contraction should be there during IUI. Nowadays, it is said that the uterus should have the contractions at the time of IUI. Then the pregnancy rate will be very good to this patient. So you can catch it with an Alice forceps. There is no harm at all, and the pregnancy rate will be very good. Don't touch, you just cross an internal os and put it inside. The most important part is that when you are doing IUI, you are actually doing intratubal insemination. So it's a common complaint of the patient that something has come out and my IUI has failed. Explain that the capacity of the uterus is only 0.4 ml. So some amount will go inside the tube and some amount will come out. And the amount that goes in the tube, and that is why it is the better pregnancy rate than the gift. That's why the gift has almost discarded from the practice. And actually, it causes intratubal insemination. That also gives a very good pregnancy rate. The rest which is required is only 15 minutes, and the luteal support is given with HCG or the progesterone can be given. 15 minutes rest is enough. There is no, and patient can do all the activities afterwards. A common question regarding the rest. There is no question of any rest. Patient can do all the activities. Now, abstinence, I told in the beginning that this should be done as a counseling, that abstinence of less than 2 days, so patient can keep sexual relation at any time. Normally, what we advise on the day of trigger, and second, we do an IUI, so it is always less than 2 days, and that gives a very good pregnancy rate. Luteal support is given because you have used gonadotropin antagonist, HCG. All these require luteal phase support, and that's why the luteal phase support is always given. And in semen preparation, you can swim up or density gradient. The very good statement is that the evidence reveals no sperm preparation technique is superior to other. So master only one technique, that will be enough, and that will be giving you excellent pregnancy. And the level of evidence is 1A. So that's why you should not go on differing your techniques all the time. But you can have a standard technique and you can do IUI. It will give a very good results. Antioxidants will be very useful, particularly when the motility is low. And particularly when after the semen collections, the IUI should be done between 40 to 80 minutes, and that have got a very positive effect on the pregnancy rate. So the contractions should be, if they are there, they give a higher pregnancy rate. Synchronization of insemination with ovulation, that is according to the PSV, you have to do the IUI, double IUI has got a better pregnancy rate at 12 and 34 hours, particularly when the PSV of the follicle is very high. So just I summarize I have got more than 16,000 pregnancies by IUI. Stimulation should be done by gonadotropin, ultrasound by color Doppler and 3D power Doppler, triggering of ovulation with HCG, highly purified or recombinant HCG, single IUI at 36 to 38 hours, double IUI if the PSV of the follicle is more than 20. Optimum was count should be at least about 6 to 8 million, but the minimum 1 million is enough. And luteal support is given by HCG or progesterone. That will give you a better pregnancy rate. Thank you very much.
Thank you so much, sir. There's so many theories which you have debunked today, actually, I think, because you talked about dual trigger even for an IUI cycle. I think Leena will We'll have some thoughts on that too. And talking about holding with the tenaculum during an IUI, because we think it should be as atraumatic as possible, but you said the logic of uterine contractions causing a increase in the sperms reaching the tube. So, what is the luteal phase support you will give when you're giving a dual trigger, sir?
See, normally in a luteal support, particularly if I have used gonadotropin, I have given HCG as a trigger or a double trigger, then I always give 400 milligram 3 times a day is an adequate dose for the luteal phase support.
Vaginal progesterone.
Vaginal, only vaginal, never oral.
Suppose she's not accepting and she's not compliant.
I have not found. This is the common question which is asked to me. But I'm practicing more than 22 years after the progesterone has come in the market. But no patient refuses for it. In India, we are very fortunate that if we give the pregnancy, they are ready to do whatever we say. So that's why you have to insist that it gives a higher pregnancy rate. The concentration to the uterus is much higher than the serum level if the patient takes. And second is the countercurrent mechanism that helps a patient a lot to accumulate the progesterone inside the uterus, and that gives a very good pregnancy rate. So that's why majority of the patients will always agree. If they don't agree, I will not prefer oral progesterone. Instead of that, I will prefer HCG. Because we used to give HCG when progesterone was not available in India. So we used to give day 5 or 9, 5,000 units, or day 3, 7, and 10. We used to give 2,000 units of HCG that stimulates the corpus luteum to secrete the progesterone.
You won't prefer an IM progesterone?
IM progesterone should be discarded. If you ask me, in the words of Peter Brisden, says that it is a crime to give intramuscular progesterone because it is so painful.
The aqueous form has come.
On the lighter side, what he said to IVF, one of the meeting, first injection should be taken by a gynecologist and second should be started from the patient.
We have taken, sir.
Never given.
Aqueous progesterone?
Aqueous is very good. Aqueous will be very good. And aqueous has totally replaced the intramuscular progesterone.
Just true. And what will be the indication of starting estradiol? You said E2 2
that
milligram
is only when you
TDS.
given an agonist trigger, because when you have given an agonist trigger, the LH surge will be for a very short duration and the corpus luteal will demise. And that's why you have to give estrogen as well as progesterone. But if the corpus luteum is active, then the E2 is not required. So unnecessary estradiol valeriate that is prescribed by many gynecologists to a patient in the luteal phase is not at all necessary. It is only when you have given agonist trigger to the patient, then and then only it is required.
Any special stimulation protocol for a PCOS patient who's going for IUI?
Chronic low dose protocol, because we calculate the scoring system, and these are the patients where we may go for 25, we may go for 37.5. The only thing to be remembered that don't increase the dose in between. It should be at least for 10 to 14 days according to the scoring system. But after 14 days, if the follicle has not developed, then you increase 50% of the original dose. So by 2022, you have to do counseling with the patient that the cycle is going to last for more than a month or 1.5 months. And normally you get the follicle by day 20 or day 22 and single follicle. I give an example, one of the patients who developed OHSS in IVF, unfortunately, laparotomy was done and then the patient had to sacrifice one ovary, maybe because of torsion or something else. That patient came to me after 3 months and chronic low dose protocol. I got only one follicle and the patient conceived. So that's why it is very important. The indication is very important. Patient has got an ovulatory defect, correct the ovulation, you will get the result.
Best results of IUI and which factor of infertility, sir? Which factor of infertility gives you the best results with IUI?
Best results are with the unexplained infertility and disovulatory infertility. These two, I can tell you that if you give me 6 cycles, I'll give you 85 to 90% results.
Endometriosis, sir?
Endometriosis first or second degree, that's fine. You can do IUI. For third and fourth degree, you have to go for IVF only. Straightway IVF.
Thank you so much, sir. Wonderfully done talk. Beautifully explained. Thank you so much. Thank you, Sneha. I'd like to thank all the coordinators, Dr. Monica, Dr. Manisha, and thankful to all the people who have done such great talks. Bye, Leena. Bye, Kalyan. Thank you so much.
And we still have a next.
Yeah, I know, I'm there. Asha ma'am's
Great to be here, Charmila. That was wonderful, sir. I'm really happy that, coming from the stalwart straight from the very authenticated person, and your experience which you have shared, I'm sure all of us have benefited a lot. And I fully agree with you, especially the vaginal progesterone. As all of you, agree that the best bioavailability which we talk about, so vaginal is the only route we prefer, and aqueous, I think maybe to some extent. Thank you so much
Even
for
I
that
would like
beautiful
to add
presentation.
and thank Dr. Nagori sir, because you have emphasized and really put your words that IUI is so important, because it is really a golden mean and choice before we subject the patient to really invasive and expensive treatment of IVF. And it does give us the results. And as you rightly said, that enough chances of IUIs should be taken before asking the patient to undergo IVF. Excellent talk, sir.
Thank you.
Thank you very much.
I'd like to now request Dr. Kalyan sir to please introduce the next speaker, Dr. Asha Baksia.
Thank you, Nagori sir, for this nice talk. And now the fourth topic will be by Dr. Asha Bakshi, who is the Honorary Secretary General of ISAR, past Vice President of FOXY. And she's a known figure in FOXY circle, as she has done so many conferences. She has got a lot of awards. She was organizing secretary of Star Endogo in 2019, ICC on 2017, ISAR 2016, organizing chairperson of AICG 22 Indore, and organizing chairperson of New Age OG Conference of 2023 of Indore. The important is that Dr. Asha Bakshi is friends of friends and teacher of teachers. So I welcome Dr. Asha Bakshi for her talk.
Thank you, Kalyan, for the kind introduction. Can I share my screen? You cannot share screen while other participants. So I think I need a permission.
Chitrikala, please allow Dr. Asha Bakshi to share the screen.
So far, the talks are really good, and especially to talk after Dr. Nagori is really, I have to really try to perform well.
Yeah, Dr. Sneha Bhuyer has started this initiative, which is really important. We need to collaborate all these IVF specialists together who are doing the practice and what is required in their practice. So now you can start your talk, ma'am.
Yeah. So today I'm going to talk on unexplained infertility. But before that, today I'm really sad because we lost our beloved Professor Bhagwat, and this is an end of the era, a very dynamic teacher, a very loving person, and a dynamic personality. So today was her Uthavna, and we are really feeling very, very sad.
Yeah, we are not able to listen to you.
Very difficult. Can you hear me?
Network issues from your side, Dr. Asha.
Sorry? You
Now
can't
you're
see the
audible, ma'am.
slides?
Yes, ma'am.
Hello?
Yes,
You
ma'am.
can't see the slides?
Ma'am, we can see your slides now. You're audible also.
Okay, fine. Thank you. Okay. So coming to the unexplained infertility, first of all, we must understand that when a couple is absolutely normal and trying for pregnancy, maximum monthly fecundity is only 20%. So couples with unexplained infertility are actually the ones who represent either a subpopulation of patients in the lower extreme end of the normal distribution of fertility, or a group of patients with a defect in fecundity which is not detected by routine infertility evaluation. And so far, there haven't been very definite definition, but recently the ESHRE guidelines have been laid, and there is a group which has discussed the guidelines. So infertility in couples with apparently normal ovarian function, fallopian tubes, uterus, cervix, and pelvis with adequate coital frequency, and apparently normal testicular function, genitourinary anatomy, and a normal ejaculate. So potential for this diagnosis is basically dependent on the methods that you use for the diagnosis. And here, again, they have included the age less than 40. What is the incidence? Incidence has been described to be almost from 10 to 30%, and the prevalence depends really on evaluation tool. After hysteroscopy and laparoscopy, the incidence reduces to less than 10%. If you add certain biochemical and molecular tests like ERA and all those things, then again, and the PCR and all those things, again the incidence will reduce. So it is basically a multifactorial disorder of reproduction, and many are based on disruption of biological processes that are crucial to functioning of the normal endometrium. And thanks to these evidence-based guidelines, which have been published by ASHRI recently on unexplained infertility, and this group, they have formulated 40 evidence-based recommendations, of which 29 were formulated as strong recommendations, 11 as weak recommendation, and 10 as good practice points, and 2 research-only recommendations. So few of these recommendations I'll discuss when I'm discussing various points. So what are the basic investigations before assigning the diagnosis of unexplained infertility? So I think our best friend is transvaginal sonography. And these days, we all have ultrasound machines in our center, and almost our PV examination has been replaced by TV exam, transvaginal sonography examination. And most of the machines these days are having 3D, 4D, all the facilities, color Doppler and everything. So you can pick up so many things, right? From the, of course, fibroids, adenomyosis, polyps, then even intrauterine adhesions can be picked up. Thin endometrium can be picked up. You can pick up the hydrosalpinx. If you can pick up the endometriosis, chocolate cysts, ovarian cysts, congenital malformations. So all these anomalies can be very well picked up by transvaginal sonography. So the day patient comes to you in your clinic, you know what is the problem. Even polycystic ovaries, ovarian reserve, this all can be picked up by good transvaginal ultrasound. So as per the ASHRI guidelines, ultrasound is recommended to exclude uterine anomalies in women with unexplained infertility. MRI is not recommended as a first line to test to confirm a normal uterine structure and anatomy in women with unexplained infertility. And if ultrasound assessment of uterine cavity is normal, no further evaluation is needed. So you should be so good that there should be no need for laparoscopy, there should be no need for hysteroscopy if you have done a good ultrasound. And these days, people are doing even virtual hysteroscopy on through ultrasound. So you have to be really very good in doing the ultrasound. And we gynecologists are the best people to do ultrasound because we have the clinical diagnosis in our hand. We know these patients and we know all these conditions. So we are much better than the sonologists themselves in doing the ultrasound, transvaginal ultrasound. Then coming to the male factor, semen analysis. Actually, in this guidelines, the male has been really not evaluated that much as they should be because they have just mentioned the semen analysis. So according to them, semen analysis is to be done 3 months apart and with an abstinence of 2 to 5 days. And it has to be according to the recent WHO guidelines. And we know that the recent manual of semen analysis has been published in 2021, where the semen volume criteria and the sperm number and all are a little bit different. So your semen analysis has to be according to the latest WHO workshop manual and WHO manual, and accordingly you can see that there is a problem. Then doing the hormone test. Routinely, we all are very fond of doing TSH, prolactin, AMH. So TSH, yes, but what the guidelines say that avoid doing lots of hormonal tests. If a patient is absolutely normal and if the menstrual cycles are regular, then you don't have to do so many tests. But I think we all have seen that subclinical thyroid does have a problem and we all tend to do TSH. About prolactin, of course, one can think about that if there are prolonged cycles, if there is scanty menses, then you can do prolactin. Coming to AMH, as Dr. Nagori said that everyone is doing AMH and he doesn't see a point. And even I feel that we don't need to really do AMH if you are very good in your transvaginal sonography and you have counted your antral follicles very well. You don't have to do AMH, but maybe for documentation purpose, AMH can be done. But again, here the guidelines, it says that in women with regular menstrual cycles, ovarian reserve testing is not required to identify the etiology of infertility or to predict probability of spontaneous conception over 6 to 12 months. So again, here they are not recommending routinely testing the ovarian reserve. Coming to the tubal test. So tubal tests, it has been recommended that HSG and sonosalpingography are good tools to evaluate the tubal factor. In the past, I still remember, even I used to do lots of laparoscopies, lots of hysteroscopies. But again, we have realized that laparoscopy and hysteroscopy is not non-invasive procedure. It does have its own problems and complications. So better to do laparoscopy and hysteroscopy only in the cases where through transvaginal ultrasound, through history, we feel that there could be a problem which we can pick up. But otherwise, routinely, if you really want to test the tube, then HSG and sonosalpingography are very good tool to evaluate the tube. And this is what has been this is what has been recommended by the ASHRIC guidelines. And chlamydia antibody testing, which is very commonly done in the West for tubal patency, could be considered a non-invasive test to differentiate between patients at low and at high risk of tubal occlusion. So that is for the, usually we are not doing that much, but we have to keep this point in our mind. And in patients at high risk of tubal abnormality, visual demonstration of tubal patency is necessary. So in those patients where you think that there is a chance of tubal abnormality, tubal block, then these are the patients where you would go for laparoscopy. So hysteroscopy and laparoscopy first or ART directly. So we all know that nowadays we are not that fond of hysteroscopy and laparoscopy as a routine for every patient. But of course, if you have taken a good history and you feel that this is a patient who has got history of fever for prolonged time, and most of the times these patients will not say that we had fever for a long time. They will say our typhoid got spoiled and we had typhoid for a long time. Or they may say that, yes, I was ill, I was admitted and I had a lot of weight loss. So these are the patients, and there are certain areas where genital tuberculosis is very common. So in these patients, I think, yes, there is a point in doing laparoscopy, because laparoscopy can pick up the peritoneal lesions like tuberculosis, genital tuberculosis, just when there is no, just in the beginning, the miliary tuberculosis where anatomical damage has not occurred, or endometriosis where it may be just the beginning, the mild endometriosis, or the subtle tubal lesions. These all can be picked up by laparoscopy. But then if you have taken a good history, on an average, you really do not need laparoscopy as the first line investigation. And similarly, so this is the subtle, these are the subtle lesions. They are like fimbrial cysts, and it has been found that laparoscopy is able to identify even tubal abnormalities like ampullary speculation, fimbrial agglutination, non-connective adhesions. And incidence of these subtle anomalies is 19.4% in patients with unexplained infertility. And when treated, then 15.7% chances of spontaneous pregnancy within 6 months. Also helps in preventing fimbrial torsion in cases of if it enlarges and it becomes a fimbrial cyst. So these are the few things which can be picked up by laparoscopy. So that is the advantage of laparoscopy, but still routinely it is not being advised. So, and again, ASHRI guidelines, they also say routine diagnostic laparoscopy is not recommended. And if at all you do laparoscopy, then I think you should be ready to treat the lesion. Gone are the days when you just used to do diagnostic laparoscopy. If at all you do laparoscopy, then you should be well prepared to treat the condition. If there is a tubal block, then you should be able to do cannulation. If there is hydrosalpinx, then anyway, hydrosalpinx does not come in unexplained infertility, but then corneal blocks can be there and these can be treated. So one has to do laparoscopy only when you're really well equipped and well trained to deal with it. So again, for hysteroscopy, the guidelines say that hysteroscopy for detection and possible correction of intrauterine anomalies is not seen as routine, not seen at routine imaging is not recommended. And HSG, if at all has to be done, then oil-based contrast medium is preferable. Then what is the treatment you have diagnosed and you can't find anything, you have and absolutely, so what is the treatment of unexplained infertility? So it can be expectant management using IUI, superovulation and IUI, or it can be IUI followed by IVF, or it can be IVF. So all these things are available, and these days what is happening is that IVF has become a standardized procedure, and the results are very good. So many a times you get pressurized. So you have to really counsel the patient well. And it has especially NICE guidelines. They used to say that, I think Dr. Nagori just now discussed the NICE guidelines. So according to them, according to the NICE guidelines, if someone has tried for, a couple has tried for 2 years and it is unexplained infertility, then it's better to go for IVF rather than IUI. But this was further criticized and not accepted even in UK. And ultimately, people prefer to do IUI versus IVF. And whenever they did IUI, then superovulation is best, as Dr. Nagori also explained, and especially in unexplained infertility. People say that gonadotropin works the best. It gives the best results with if you want to do IUI, then you can do with a very low dose gonadotropin stimulation and then do IUI. That gives you very good results. So this is a paper of IUI versus IVF in unexplained infertility. And the conclusion was that live birth rate in 3 cycles of IUI is not significantly different from 1 cycle of IVF. And IUI is so natural. There is no need for the lab and gametes are not disturbed. So basically, it is really just assisting the natural process a little bit. So that way, I personally, if anyone asks me, then I would go for IUI. So again, the guidelines, what do the latest guidelines say? And they say that IUI with ovarian stimulation is recommended as first-line treatment for couples with unexplained infertility. So all that NICE guidelines and all that is all gone. Now it is, we all are going to follow the ESHRE guidelines. So this group advises to base the decision to start active treatment on prognosis in couples with unexplained infertility. So naturally, whenever you discuss all those things, then you have to take the couples and you have to counsel them, explain to them. And many times the couples do not agree and they want to go straight away for IVF. So, but overall, IVF is not recommended over IUI. And it is expected that the decision to use IVF is individualized by the patient characteristics, such as age. Naturally, if she's elderly, then better to go for IVF. Then duration of infertility, if it is very long, then what previous treatment she has undergone, and especially if she has had repeated cycles of IUI. Yes, Dr. Nagori did say 7 cycles of IUI, but where is the patience? No, the patients do not have patience. So most of us are practicing a number 3 to 4 IUI and then going with for IVF. And if she has had previous pregnancy, then you have if she has had previous pregnancy, then you have to see what it was, how it was, and how much you can wait. So IVF again is a fast track treatment, and in certain conditions you may have to do it, but otherwise for unexplained infertility, still the first line treatment is IUI with ovarian stimulation with using gonadotropins. Then ICSI is not recommended over conventional IVF in couples with unexplained infertility, but I think most of us are these days practicing ICSI. Or what can be done is you can do half eggs as ICSI and half eggs as IVF. And usually what you see is that the fertilization rate in IVF is very less. But the guidelines say that ICSI is not recommended, and IVF is better. And there are many people who argue against ICSI for all. So those are subtle differences, but I think practically people are doing ICSI for all. Now, there is a lot of talk about the microbiota. So, should vaginal microbiota be tested? So, here again, they said that vaginal microbiota testing could be considered in couples with unexplained infertility only in research setting. And in our country, I think we are giving microbiota to, we are giving probiotics to our patients, and especially there lots of discussions are coming about microbiota leading to PCOS, microbiota leading to recurrent implantation failure. So we are all getting tempted to give probiotics to these patients. Then cost effectiveness of IUI versus IVF. And in this particular paper, it was said that for couples with unexplained and mild male factor subfertility, primary offer of a full IVF cycle is less expensive and more cost.
Ma'am, you're not audible. Asha, ma'am, you're not audible.
I think some network issues once again from her side.
Ma'am.
Manisha, you can call, ma'am.
Ma'am. Yes, ma'am, calling.
So till Madam joins, Lena, would you like to comment on the talks of your session? Especially the IUI talk by Nagori sir.
It was very informative talk indeed. And
how much of an IUI person are you? Because I know Lena spends quite a lot of time in the lab also.
yeah, we do IUI. We do. It depends upon the case to case, differs how many cycles, but definitely 3 cycles of IUI is must for the patients who are for the IUI. And sometimes if in younger couples in unexplained infertility, we do extend that to 5 cycles also. But it requires a lot of counseling, because patience as is very, very important, and assurance that because in any ways IUI has maximum rates of 15%, not more than that. Let's be very practical and let's be very honest with it. So gone are the days when you must be remembering, Monica, when we were younger and at the beginning of the practice, when we started IUI, people used to claim IUI results as high as 60% and 40%. So let's be very practical, but you that counsel that to a couple. And even if we jump to IVF, it's not 100%. It rises from 15% to 40%. So many couples are under impression that if we do IVF, you are going to get a baby, or 100% results are guaranteed. So I am of the opinion that if everything is good, if age is on the side and everything else is okay with the patient, you can try IUI for 5 times. Of course, with lot of counseling. IVF is, of course, a short method, but again, it's not 100% guaranteed.
100%.
So I am an IUI person, definitely.
Thank you. What about Asha, ma'am? Manisha, did you have a...
She's trying to join back again.
Right. Maybe.
There's a network issue.
And during IUIs, when you are, taking attempts or doing so much superovulation, we don't start with superovulation right away, but with monofollicular first, because we all have the target of, singleton pregnancy. But then it prepares the mindset of the patient also. Patient automatically gets prepared for IVF. She is convinced that enough has been tried on her. And so less counseling is required for the preparation of.
Definitely. Okay,
So
Lina,
that also
I
helps.
think
Madam has joined.
for excellent
Yeah.
inputs, and Asha ma'am is back again. Madam, can we go back to your talk, ma'am?
So
We will-
I think now I'll be
welcome
not be
back.
able to talk because something is has gone wrong with the internet, and it will be difficult. But it
Oh,
was almost I was about to finish. So my conclusion is that you have to really try to explain the unexplained infertility rather than just take it as it is, and because that will really improve your treatment. And as such, most of the treatments for unexplained infertility are empirical, but one has to still, whatever it is, we have to stress a lot even on lifestyle, which we usually forget, because in unexplained infertility many times nothing works, and the still if the patient is having good lifestyle and all of a sudden you find that spontaneous conception has occurred, and IUI has a good role for these patients. It is a primary treatment, but sometimes if the patient is not willing, then you may have to fast forward the treatment of IUI. So
ma'am,
that's
that's what Dr. Lina was also saying. Dr. CB Nagori is definitely a proponent of IUI. Lina is, we are same age, and Lina definitely believes in IUI. Madam, you have spoken for IUI. Now, it all depends that use of tenaculum, number of cycles. So this is never-ending controversy.
yeah.
But I still feel that we should follow guidelines. And ma'am, you must be agreeing, Asha ma'am. Now, ESHRE guidelines has made IVF and ART simpler. They
Yeah.
are reducing the burden. They are
Yeah.
reducing the
And
cost.
I think especially laparoscopy, I think we have to understand that laparoscopy is an invasive procedure. So use it selectively and use it only when you can really treat this patient. Otherwise, just gone are the days of simple diagnostic laparoscopy or hysteroscopy.
Yes, definitely. Dr. Kalyan, any remarks from your side?
I think unexplained
My
infertility
endoscopy
is
person. Your endoscopy
uh,
person, basically.
no, unexplained infertility
He's
is
an
an
all-rounder, ma'am.
enigma. It's an enigma where a patient is more needs to be counseled psychologically, because all the reports are normal, still they are not conceiving. So the first part is psychological assessment. You have to counsel them properly, change of lifestyle, and one more important factor I take care is the AMH levels. So if AMH levels are good, then only you should go for a more than 3 or 4 cycles of IUI, which sir was talking. Otherwise, I don't go beyond 4 IUI cycles. And lastly, laparoscopy is the gold standard. Whenever you can't find something, as Dr. Bakshi will agree with me, so many patients with genital tuberculosis, grade 1 or grade 2 endometriosis, or even on hysteroscopy, you can find polyps, adhesions. So that is what is important, is histolaparoscopy is gold standard whenever in a case of unexplained infertility. Thank you, Dr. Asha madam, for this talk, innovative talk. You have covered almost all points, and now you have concluded about the role of IV laparoscopy, IVF ICSI in cases of unexplained infertility. ICSI remains the last part of this, but as Dr. Lina was saying, you have to look into the patient's aspects also, that you are going to do 4 IUI, 10 IUI, that is not accepted in today's modern world, because women are getting married very late. So we get patients within 1 year of marriage, age 37, 30, they want directly IVF. So these are the
Yes.
patients where you have to judge them differently. You can't have a similar protocol for all
Yeah.
these patients. And
After one IUI,
Definitely,
they
I
don't
think
want to go.
age at marriage and the duration of infertility definitely have the impact on the way of management. Definitely, everybody's talking about stress management. I think we had a very basic talk initially, so we actually highlighted the detailed history, the complete physical examination, and the detailed evaluation. As all of you must be remembering that all the basics were concerned here, and of course the hysterolaparoscopy being the gold standard investigation for infertility. That is what we talked about. Definitely IUI, as all of us are saying, that we should follow the guidelines. Definitely as long as there are no further guidelines, we have to stick to these only, I think. And definitely stalwarts like Dr. C.V. Nagori can make the comments with his experience. But all of us have to come together and present your data and analyze, so that all of you can come up with some guidelines. And I think that will be the benchmark for all of us. Thank you so
Yes,
much.
ma'am. Dr. Sneha, ma'am, I like to just make one point here. The time slot to be patient to be successful, you need to give them a time slot that within 6 months, 1 year, we are going to try this modality and now going to shift to this modality. So time efficient investigations of entire infertile patients are also important.
Yes, yes. So we did have one slide, if you remember, Monica, that saying that you have to be very realistic to the patient and the relatives, and you have to counsel them that yes, over a period of time, things are going to be, we are going to manage this, and over a period of this time slot, you may conceive or you may have these, after effects, so that the patient is ready to, go through the treatment, and she's ready even to accept the whatever results are there for the treatment. Definitely, you have some options to be given to the patient, that if this fails, what is the next, so that you have good compliance from the patient side. Fortunately, we could cover this during the first talk. And I would once again thank all of you, all my esteemed faculties who are the bigwigs of infertility and IVF management. I have already thanked all the stalwarts who were the chief guest of honor and special guest. And I once again thank the esteemed speakers, Dr. Sanjeeva Reddy.
We thank Dr. Sneha madam for involving us into this.
Thank you,
And
madam. It was pleasure.
she's the
Listening
most
to all the
deserving person.
important topics.
I have seen her since last 20 years. She's a real asset to the Foxy, and I wish all the best for her elections. She's going to win these elections effectively. Thank you so much, ma'am.
Thank you so much, Kalyan, for your best wishes and all your wholehearted support. And thank you so much, all of you, once again.
Thank you, Dr. Monica and Dr. Manisha.
Monica, over to you.
Thank you, Sneha ma'am, for the opportunity. Thank you, Dr. Kalyan. Thank you, Dr. Leena. And thank you all speakers and dignitaries. And madam, wish you all the best for the benchmark series. We are always there at your service whenever you need us.
Thank you so much, Ajay, Monica, and thank you, Leena, and wish you all the very best to you as well for your elections.
Ma'am, for us, you have already won the election.
Yeah. Thank you. Good.
Thank you so much.
Thank you. Thank you, Sahiti.
Thank you.
Thank you,
so
Chitra.
much. Bye-bye. Bye.
Thank you. Thank you to the tech team.
Next session is on gynae endoscopy, and we